Chapter 17 is over digestive system disorders. So again, please review the A and P of the digestive system on your own. It's pages 431 through 437 in your book. We're going to jump right into digestive system disorders. So first we have anorexia, anorexia nervosa, nausea, vomiting, bulimia. So anorexia in general is just the loss of appetite. Nausea and vomiting might be signs of the digestive system disorders or other conditions like infections, kidney failure, emotional responses like fear, motion sickness, pressure in the brain, drugs, or pain. Vomiting is also one of the body's defenses. It removes bad substances from the body. Anorexia and vomiting can lead to serious complications like dehydration, acidosis, and malnutrition. Anorexia, again, that general loss of appetite, usually precedes nausea and vomiting. You lose your appetite and then you get nauseous and vomit. Remember that nausea is a subjective feeling. The person might look sick, but we don't specifically know that they're nauseous until they tell us. It's stimulated by distension or irritation or inflammation of the digestive tract. Some symptoms include increased salivation. When I was little, I told my mom that my mouth was sweating, and I still remember it like that. Like you have that salivation, but it's definitely a different type of salivation in the mouth. Pallor, sweating, tachycardia. Vomiting or emesis is the expulsion of chyme from the stomach and sometimes from the intestine. The vomiting center in the medulla is activated by things like distension or irritation in that digestive tract, stimuli from different parts of the brain in response to certain sights or smells, or ischemia or pain or stress. The vestibular part of the inner ear, like in motion sickness, or increased intracranial pressure. This is usually responsible for projectile vomiting because of that pressure on the vomiting center in the brain, or by stimulation of the chemoreceptor trigger zone in the medulla, like by drugs, toxins, and chemicals. Drugs can also cause vomiting just by irritating the digestive tract. Bulimia is an eating disorder when someone binges and overeats, followed by inducing vomiting, taking laxatives, or starving themselves to avoid weight gain. There are significant adverse effects on the digestion process and some of the digestive structures, including damage to structures of the oral cavity because of frequent exposure to stomach acid, tears in the esophagus, constipation, diarrhea, and electrolyte and nutritional imbalances and deficiencies. And remember that anorexia itself is just a loss of appetite. Anorexia nervosa is the eating disorder where people obsess about their weight and what they eat. People refuse to eat an adequate amount of food to meet the nutritional needs of the body. The vomiting center in the brain can be activated by, like I said, distension or irritation in the digestive tract, stimuli from other parts of the brain, pain or stress, the vestibular apparatus in the inner ear, increased intracranial pressure, and stimulation of chemoreceptor trigger zones. This is on page 439. It shows that vomiting reflex. The characteristics of vomit can tell us a lot. The presence of blood can look two different ways. Coffee ground emesis looks just like coffee grounds and tells us that there's a bleed lower in the GI system. And frank red blood tells us that there's a bleed upper in the GI system. Yellow or green vomit usually contains bile. A deep brown color can indicate vomit from the lower intestines. This usually happens when there's an obstruction, so the stool can't pass normally and it has to go somewhere, so it comes up. Recurrent vomiting of undigested food tells us that there's a problem with gastric emptying, like an obstruction of the pylorus. And then diarrhea, it's an excessive frequency of stools, usually loose or watery. It can be acute or chronic. It's usually accompanied by nausea and vomiting when there's infection or inflammation of the digestive tract. Otherwise, it can happen by itself. The person usually feels cramping and pain with it. Severe or prolonged diarrhea can lead to dehydration, electrolyte imbalances, acidosis, and malnutrition. There's a couple common types of diarrhea. We have large volume diarrhea, which is secretory or osmotic. Watery stool results from an increase in secretions into the intestines from the plasma. It's usually related to some sort of infection. Limited reabsorption happens because of reversal of the normal carriers for sodium or glucose. And then small volume diarrhea. This is usually caused by an inflammatory bowel disease. The stool could contain blood or mucus or pus, and it could also be accompanied by abdominal cramps. Then we have steatorrhea, which is fatty diarrhea. It's frequent, bulky, greasy, loose stools with a very foul odor. It's a characteristic of malabsorption syndrome like celiac disease or cystic fibrosis. Fat usually is the first dietary component that's affected. The presence interferes with digestion of other nutrients, and the abdomen is often distended. And then we have blood in the stool. So blood can happen in normal stools with diarrhea, constipation, tumors, or some sort of inflammatory issue. We call that bright red blood that, I guess when we think of blood, this is what we think of, frank blood. It's usually from like lesions in the rectum or in the anal canal, so very far down in the GI system. And then we have what we call occult blood, which is a small hidden amount. So we don't see it at all, but we can detect it with a stool test. So if we suspect that there's a potential bleed, we'll check a stool test to be sure. This could be caused by some small bleeding, like in ulcers. Some ulcers bleed a lot heavier, but small bleeding. And then we have what we call melena, which is a dark colored tarry stool. It's like very dark, almost black, and it's sticky and it looks just like tar. This happens when we have a GI bleed that's further up in the digestive tract. Then we have gas. So gas develops in the digestive tract from swallowing air and the digestive and bacterial action on food. Certain foods or changes in motility or movement through the GI system can also increase gas production. Excessive gas causes belching, which is called irritation, and borborygmus. So borborygmus, I think that's a funny word, but it's exactly what it sounds like. It's that rumbling or gurgling noise in the GI tract. Gas can also cause abdominal distension and discomfort, or flatus, which is the passing of gas. Constipation is less frequent bowel movements than normal. Clinically, we diagnose constipation when it has been I believe 3 days without a bowel movement, but it really could vary from person to person. So just in general, less frequent bowel movements than normal. The stools will be small and hard. I joke about it being like the deer pellets. It could be an acute or a chronic problem. Some people are more susceptible to having constipation. They have it more often. And then some people only get it occasionally or with, certain issues. It could be caused by a decrease in peristalsis, which is that movement through the GI system, because as that movement slows down, the stool sits in the large intestine longer and more fluid is absorbed. So that just leads to, a large amount of, hard, less lubricated stool in the GI system. Some people have periods of constipation that follow periods of diarrhea, and it's kind of like a back and forth pattern. But chronic constipation can actually cause problems like hemorrhoids, anal fissures, and diverticulitis. So some different causes of constipation. For one, the weakness of smooth muscles because of age or illness. So that peristalsis or movement through the GI system is all a muscle movement. So if we have weakness in that muscle, the smooth muscle of the GI system, we're going to have slowing of that movement. Inadequate fiber intake, inadequate fluid intake, failure to respond to the defecation reflex. So what that means is just holding it for too long. So when you need to go, you need to go, because if we don't respond to that reflex or that need to go, it can lead to constipation. Immobility, if you think about how, if you go for a run or if you become extremely active, that stimulates that movement through the GI system. Immobility does the exact opposite. If we're just staying put, that's going to keep that mobility or that movement through the GI system at a much slower rate. some different neurological disorders that don't allow us to understand or realize that sensation or have that sensation that we need to go. Different drugs, especially opiates, narcotic pain medications, some antacids and iron medications can also cause constipation, especially if they're overused, and obstructions by tumors or something like that can also cause constipation. So some fluid and electrolyte imbalances, dehydration and hypovolemia are common complications of digestive tract disorders. Electrolytes are lost when we vomit and have diarrhea. So metabolic alkalosis can result from hydrochloric acid being lost when vomiting, and metabolic acidosis, so severe vomiting causes a change from that alkalosis to acidosis because we lose the bicarbonate of the duodenal secretions in that as well. So if we just have some basic vomiting, we are in possibly metabolic alkalosis because we lose hydrochloric acid. If it is severe, then it shifts over to metabolic acidosis because we're losing that bicarbonate. Diarrhea also causes a loss of bicarbonate as well. Then we have malnutrition. So malnutrition just means bad or poor nutrition in general. It can be an excess or a deficit issue. It can be specific, like a vitamin B12 deficiency or iron deficiency, or it can be generalized. Some generalized malnutrition issues can be from chronic anorexia, vomiting, diarrhea, or inflammatory bowel disorders, cancer treatments, wasting syndrome, or lack of available nutrients. It can also be related to malabsorption. So if you're taking in plenty of nutrients but not absorbing them, it's kind of as if you're not taking them in at all. And then, so to diagnose any GI problems, we can do radiography like x-rays, usually with barium that we either give to drink or as an enema to help outline the GI structures and abnormalities. We can do ultrasounds to detect masses, CT scans and MRIs to check liver or pancreatic abnormalities. Endoscopy is used to examine the upper GI tract, and we can take biopsies while we're in there. Sigmoidoscopy and colonoscopy are used to examine the lower GI tract. Again, we can take biopsies and remove polyps. We do labs to check liver and pancreatic function and to check for cancer markers, and we analyze stool specimens to check for infection, parasites, bleeding, tumors, or malabsorption. So different treatments and prevention for GI issues. First, we have dietary modifications. That's probably the biggest one. So for someone who, for example, has celiac disease, we would go with a gluten-free diet. We also recommend decreasing the intake of alcohol and coffee and increasing fiber and fluids. We also want to help reduce stress because stress impairs immune function and tissue healing. And then there's a variety of different medications that are available for each different type of issue with the GI system. So now we're going to talk about upper GI tract disorders. So when we're talking about the upper GI system, again, that starts with the mouth. So we have some disorders of the oral cavity. First, we have congenital abnormalities like cleft lip and cleft palate. These arise in the 6th to 7th week of gestation. They're more likely a multifactorial issue. It causes feeding problems in the infant. They're at high risk for aspirating fluid into the respiratory passages. Speech development becomes impaired, and surgical repair needs to be done as soon as possible, along with therapy with a speech language pathologist and an orthodontist. So this is the cleft palate, as you can see here. Another disorder of the oral cavity is candidiasis. It's an infection. The Candida albicans is the causative agent. It's often part of the resident flora in the mouth, but it is an opportunistic, or resident flora in the body, but it's an opportunistic organism that can lead to that oral candidiasis or thrush. People receive broad spectrum antibiotics to treat it. A lot of people get it during and after cancer therapy. Immunocompromised people or people with diabetes get it more frequently. We see it a lot when people that have like inhaled medications like inhalers or nebulizer treatments, if they don't rinse their mouth out properly afterwards. So it can appear as red, swollen areas. There might even be irregular patches of a white, like curd-like material. And here's a picture of that white, like, I don't know, kind of cottage cheesy type issue. We also have herpes simplex type 1 or HSV1. It's transmitted by kissing or by close contact. The virus remains dormant in the sensory ganglion, and then it's activated by things like stress, trauma, or other infections, and it forms a blister or an ulcer or a clear, there's a clear fluid that's released that contains the virus. It can be auto-inoculated to other areas. So what that means is like if you have it yourself and you touch this fluid and then you touch maybe say like the other side of your mouth, you can transfer it over to other areas. The lesions do heal spontaneously in about 7 to 10 days. The acute stage can be alleviated by antiviral medication. We do have to worry here because it can be spread to the eyes in conjunctivitis and keratitis. So again, might be like if you have it, like this sore on your mouth, and you happen to touch it or whatever, and then you itch your eye, it can develop into the conjunctivitis. It can also lead to herpetic whitlow on the fingers, and this is a picture of that. Then we have syphilis. It's caused by the Treponema pallidum virus. It can cause oral lesions. It's highly contagious during the first and second stages. The primary stage, there will be like a canker, which is a painless ulcer on the tongue, lip, or palate, and it heals spontaneously within a couple weeks. Then in that secondary stage, there are red macules or papules on the palate, which are highly infectious. Those also heal spontaneously. Both stages are treated with long-acting penicillin. And then we have dental caries. Caries are cavities, in case you were unaware of that terminology. So there are different organisms that can cause dental cavities or dental caries. The bacteria on the teeth break down sugars or in the mouth, break down sugars and produce large quantities of lactic acid. That lactic acid dissolves mineral in the tooth enamel, and tooth erosion and caries or cavities form. The caries are promoted by frequent intake of sugars and acids, and then the treatment to prevent dental caries or cavities is fluoride, as well as regular oral care to remove the sugars and acidic fruits and drinks and stuff like that. Then we have gingivitis, which is changes in the gingiva or the gums. This can be local or a systemic problem. Inflammation of the gums when the tissue becomes red, soft, and swollen and bleeds easily can be a result from accumulated plaque. Gingivitis can also be because of inadequate oral hygiene or toothbrush trauma. So a lot of people want to brush with a really hard bristled toothbrush because they feel like their teeth get cleaner that way. But really it's best to use a soft bristled toothbrush because then you're not causing all this trauma to the gums. So toothbrush trauma happens from improper or excessive brushing, and it creates extensive grooves on the tooth surface, and increased plaque is retained there, and it can cause damage to the gums or the gingiva. Periodontal disease is an infection and damage to the periodontal ligament and bone. The predisposing condition is gingivitis, so gingivitis can lead to periodontal disease. It's caused by microorganisms as a result of poor dental hygiene, and it can lead to a loss of teeth. There's different categories and different degrees of the disease. We're not going to get into that, but it can be aggravated by systemic diseases and medications that reduce the saliva in the mouth. Saliva is actually pretty acidic, and it helps kind of get rid of pathogens and stuff like that. So if you're decreasing the amount of saliva in the mouth, and that can be an aggravator for periodontal disease. So this is the healthy periodontium, and then this is severe periodontal disease. And there's many other pictures of teeth in your book if you would like to look at the variety of different, oral issues. They kind of start, there's more pictures of like the cleft palate and stuff like that on page 444. And then you can see all kinds of lovely pictures on 448 and 449 of the different issues in the mouth. So periodontitis happens when organisms enter that gingival blood vessels, the gum blood vessels, and travel to the connective tissues and bone of the dental arch. Resorption of bone and loss of ligament fibers result in weakened attachment of the teeth and can result in total loss of the teeth from the sockets. It is treated by antimicrobials or potentially even local surgery of the gums and improved dental hygiene. So then moving from the mouth and kind of into like the neck area, we have dysphagia, which is difficulty swallowing. Causes here a very, sometimes it's a neurological deficit, like after a stroke or a brain injury or something like that. It could also be a muscular disorder because we have lots of muscles that aid in our swallowing. Or it could be a mechanical obstruction if we have something literally obstructing, our airway, or sorry, not our airway, well, potentially the airway too. But if we have an actual obstruction in that area, then it can lead to issues with swallowing. So it results in pain with swallowing, or the inability to swallow larger pieces of solid material, or difficulty swallowing liquids. Some people have some of those, some people have all of those. It just depends. It varies from person to person and the degree of the issue. If it's a neurological deficit, it could be, like I said, from a stroke or brain damage, but it could also be from an infection or an issue with the lower esophageal sphincter relaxing because of a lack of that like muscle tissue there. It could be a muscular disorder, like an impairment from muscular dystrophy, many other muscle, disorders, as well as people age, their muscles kind of become weaker anyways. And then, like I said, a mechanical obstruction. When we're talking about a mechanical obstruction, it can be a physical, a thing in there like a tumor or whatever, but it can also be an issue with, narrowing of the esophagus and stuff like that too. So this is on page 450, and it shows the different causes of dysphagia and why it would cause an issue with swallowing. Then we have a hiatal hernia. This is when part of the stomach protrudes into the thoracic cavity. We have a sliding hernia. This is more common. It's when portions of the stomach and gastroesophageal junction slide up and above the diaphragm. And then a rolling or paraesophageal hernia, it was when part of the fundus of the stomach moves up through an enlarged or weakened hiatus in the diaphragm, and it can actually become trapped there. There's these pictures on page 451 of the different hiatal hernias. So when we have a hernia, the food can lodge in the pouch of the hernia and cause inflammation of the mucosa. We can also have reflux of the food up the esophagus, and it can cause chronic esophagitis. Some signs are heartburn or pyrosis, frequent belching, increased discomfort, especially when laying down, and substernal pain that can radiate to the shoulder and the jaw. Then we have gastroesophageal reflux disease, or GERD. This is periodic reflux of gastric contents into the distal esophagus that causes erosion and inflammation. It's often seen along with a hiatal hernia. The severity depends on the competence or the ability of the lower esophageal sphincter to close appropriately. Delayed gastric emptying could be a factor, so we're holding the contents in our stomach a lot longer, and before they go into the small intestine, so the contents are more likely to back up into the esophagus. If someone has GERD, we recommend avoiding caffeine, fatty and spicy foods, alcohol, smoking, and certain medications and drugs. And then we recommend certain medications to reduce the reflux and inflammation. Then we have gastritis. So gastritis is an inflammation of the stomach. In acute gastritis, the gastric mucosa is inflamed and red and edematous. It might be ulcerated and bleeding if it's severely damaged. It can result from infection, allergies to foods like shellfish or different drugs, ingestion of spicy or irritating foods, excessive alcohol intake, ingesting toxic substances, radiation, or chemo. Basic signs of gastrointestinal irritation are anorexia, nausea, and vomiting. Hematemesis can also happen, which is vomiting up blood. This is caused by bleeding in the GI system. Epigastric pain, cramps, or general discomfort with infection, diarrhea can develop. Acute gastritis is usually self-limiting, so complete regeneration of the gastric mucosa can happen within a day or two. We treat the vomiting with meds, and the person might also require antimicrobial drugs for certain infections if that's present. Chronic gastritis is characterized by atrophy of the stomach mucosa, loss of the secretory glands, and reduced production of the intrinsic factor. H. pylori infection is usually the causative issue here. Signs can be vague from mild epigastric discomfort, anorexia, and intolerance of certain foods. This increases the risk for peptic ulcers and gastric cancers. Certain autoimmune disorders are associated with one type of chronic gastric atrophy, but just the one. And then we have gastroenteritis. So this is inflammation of the stomach and the intestine. It's usually caused by an infection. It can also be caused by allergic reactions to food or drugs. Microbes can be transmitted fecally by fecally contaminated food, soil, or water. So a lot of times this is like a food poisoning type of issue. Most of the infections are self-limiting. They go away on their own. Very serious illnesses could result in a compromised host or virulent organisms. It can cause epidemic outbreaks, especially if there are areas with poor sanitation and things like that. Safe sanitation is essential for prevention here. This table is on 453 in your book. It might be good to look at. It compares the different common infections that are transmitted by food and water. Then we have peptic ulcer disease. It's specifically, gastric and duodenal ulcers. Again, most likely it's caused by H. pylori. It usually happens in the proximal duodenum. It can also be found in the antrum of the stomach. The development begins with a breakdown of the mucosal barrier, causing a decreased mucosal defense. It's more common in gastric ulcer development, and its increased acid secretion is a predominant factor in the duodenal ulcers. So this shows the common locations that we just talked about on page 455. So damage to the mucosal barrier predisposes development of ulcers, and it's associated with inadequate blood supply, excessive glucocorticoid secretion or medications, ulcerogenic substances that break down the mucus layer, and atrophy of the gastric mucosa, as well as an increased acid pepsin secretion that increases the gastrin secretion, the vagal stimulation, sensitivity to vagal stimuli, the number of acid pepsin secretory cells in the stomach, stimulation of acid pepsin secretion, and interference with normal feedback mechanisms, and rapid gastric emptying. Some complications of peptic ulcer disease or hemorrhage. This is caused by erosion of the blood vessels. It's a common complication, and it actually can be the first sign of a peptic ulcer. Perforation, where the ulcer erodes completely through the wall. Chyme can enter the peritoneal cavity at that point and results in chemical peritonitis, and then also obstruction, which can happen later because of the formation of scar tissue. Signs and symptoms are epigastric burning or localized pain, usually following stomach emptying, and usually that pain or burning kind of goes away as we are eating, because when we're eating, it kind of coats that ulcer, prevents the acid of the GI system from irritating it. So to diagnose, we do an endoscopy, we take some x-rays with barium, and we can also do biopsies. To treat, we do a combination of different medications, so we can do some antibiotics and proton pump inhibitors to get rid of the H. pylori, and then we want to reduce the exacerbating factors if we know them. And then we have disorders of the liver and pancreas. So gallbladder disorders, chole just means gall. So cholelithiasis is the formation of gallstones. Cholecystitis is inflammation of the gallbladder and cystic duct. Cholangitis is inflammation that's usually related to an infection of the bile ducts. And cholecystolithiasis is obstruction of the biliary tract by gallstones. So this is on, sorry, I didn't flip along. This is on page 460, and it shows the biliary ducts and the pancreas and where the potential locations of gallstones could be. So gallstones vary in size and shape. They form in the bile ducts, the gallbladder, or the cystic duct, and they can consist of cholesterol or bile pigment, or mixed content with different calcium salts. Small stones could be, unagitating. You don't even know that they exist, and they're excreted in the bile. but larger stones can obstruct the flow of the bile in the cystic or common bile ducts and cause severe pain, which is often referred to in the subscapular issue or area, or like the shoulder blade area. We associate that with gallstones. So this actually shows the gallbladder with gallstones. I feel like those look huge and unrealistic, but that's an actual picture. So some risk factors for gallstones. Women, women are twice as likely to develop them. Someone that has a high cholesterol intake, or obesity, or multiparity, which just means multiple pregnancies, or someone that is using oral contraceptives or estrogen supplements, someone with hemolytic anemia or alcoholic cirrhosis, or a biliary tract infection as well. Obstruction of a duct by large calculi stones causes sudden severe waves of pain that radiates, like I said, usually to that shoulder blade area. Usually the person is also going to have nausea and vomiting. The pain, if the pain continues and jaundice develops because of the bile backup into the liver and the blood. They risk a ruptured gallbladder if it is not taken care of immediately. If the rupture happens, pain will decrease. Pain will actually also decrease if the stone moves into the duodenum. So when we have all that pain and then we have a sudden relief of the pain, then is it just the stone moving, or do we have a rupture? So surgical intervention might be necessary. Usually if the gallbladder is what we call like hot, if it is, irritated and stuff like that, we're just going to go take it out. We're not going to wait around and wait for something like a rupture to happen. So we might remove it using laparoscopic surgery, and then the person would need to refer to a low-fat diet after surgery. So then we have jaundice. We have prehepatic jaundice. This is the result of excessive destruction of red blood cells. Intrahepatic jaundice happens when disease or damage when there is disease or damage to the hepatocytes, and posthepatic jaundice is caused by an obstruction of bile flow into the gallbladder or duodenum. This is on page 462. It compares the different types of jaundice. So the type of jaundice is indicated by an increase in serum bilirubin level and changes in stools. Again, that prehepatic jaundice, there will be an unconjugated bilirubin level that's elevated. Intrahepatic jaundice will be both unconjugated and conjugated that are elevated, and then posthepatic will be increased conjugated bilirubin level and light-colored stool because there's an absence of the bile. Then we have hepatitis. So hepatitis is an inflammation of the liver. It can be idiopathic, like a fatty liver, or from an infection like viral hepatitis, or from an infection somewhere else in the body like mono, or from chemical or drug toxicity. Inflammation impairs hepatocyte function and can lead to necrosis that leads to obstruction of blood and bile flow in the liver and impaired liver cell function, leading to extensive effects on the body. So the cell injury results in inflammation and necrosis in the liver. The degrees of inflammation and damage can vary. The liver is going to be edematous and tender. There's different viruses. There's Hep A, Hep B, Hep C, Hep D, and Hep E viruses that could be causative here. Hep A is an infectious hepatitis. It's transmitted by the fecal-oral route in areas of inadequate sanitation or hygiene. Usually it's from contaminated water or shellfish, because the shellfish could be in the contaminated water, and then we end up eating them. Sexual transmission has happened during anal intercourse. It's an acute but self-limiting infection. There's no carrier or chronic state here. There's fecal shedding of the virus before there's an onset of signs here. So Hep A, again, it's more likely to happen in underdeveloped areas that have poor sanitation issues, but it's definitely potentially foodborne as far as, poor sanitation from workers here. There are vaccines available for travelers, food care workers, and healthcare workers. A lot of times people that are going to travel to other countries will get the Hep A vaccine. And this is exactly why a lot of times if you go to a different country, it is recommended that you do not drink the water. You will only drink bottled water because of potential Hep A. Hep B is is chronic inflammation. Over 50% of HIV positive patients are positive for Hep B, and 50% of patients are asymptomatic but contagious because of that carrier state. The transmission is primarily by infected blood. Sexual transmission is potential, but again, it's going to be contaminated blood. So if there's like a blood exchange during the sexual intercourse, then possibly. Here we can see it with tattooing and body piercing, as well as like shared needles and things like that. There is a vaccine available. It's usually given to kids, and it's required most often in the world of healthcare to work. And then Hep C is the most common type of blood transmitted hepatitis. It can happen by a blood transfusion, but really in the United States back in the 60s, we started regulating our blood before we, screening blood before we use donor blood. So it's very unlikely. But if you end up getting a blood transfusion in another country, then it's possible. It can exist in a carrier state. About half of the patients enter a chronic state, and it increases the risk of hepatocellular carcinoma. It's treated with interferon injections, and this is the one that, again, you're going to get either sexually transmitted or you're going to get it by like sharing needles or something like that, bloodborne. Hep D is also a blood transmitted hepatitis, but if you have Hep D infection, it increases the severity of Hep B. It requires a Hep B virus to replicate, so Hep D and Hep B go along together. You're never going to have Hep D by itself. And then Hep E is also transmitted by that oral fecal route. It's just not as common as Hep A. So signs and symptoms of any hepatitis, we have the pre-icteric stage where the person is going to feel fatigue and malaise, anorexia, nauseous, general muscle aches. And then the icteric stage where they have that onset of jaundice. So that's going to probably be our first indicator because the pre-icteric stage is pretty vague. And in that icteric stage, you'll also see lighter stools and the urine will become darker. The liver may become tender and enlarged and might ache as well. And then the post-icteric stage is the recovery stage where there's a reduction in signs, but the person is probably going to be weak for weeks. The weakness will persist for quite a while. The only body defense is formation of antibodies via vaccine for viral hepatitis, and then we use supportive measures like rest, a diet that's high in protein, carbohydrates, and vitamins. And then chronic hepatitis can be treated with interferon that decreases the viral replication. Then we have cirrhosis. So this is a progressive destruction of the liver. Some causes are alcohol. Biliary cirrhosis is associated with immune disorders. Post-necrotic cirrhosis is linked with chronic hepatitis or long-term exposure to toxins. And metabolic cirrhosis is usually caused by genetic metabolic storage disorders. So in cirrhosis, there is extensive diffuse fibrosis that interferes with the blood supply, and there might be a backup of bile. There's a loss of lobular organization, and degenerative changes can be asymptomatic until the disease is advanced. So that becomes, problematic because we don't realize what's going on until it's advanced. A liver biopsy and blood tests determine the cause and extent of the damage. The initial stage is a fatty liver, especially with alcoholic liver disease, which just means enlargement of the liver. It can be asymptomatic and reversible, especially with reduced alcohol intake. The second stage is alcoholic hepatitis with inflammation and cell necrosis. There's fibrous tissue formation, and this is irreversible. So that initial stage, that fatty liver, that is reversible. Once you advance into the second stage, the alcoholic hepatitis, it is no longer reversible. Permanent damage. The third stage, end stage cirrhosis, is when there's fibrotic tissue that replaces normal tissue and there's little normal function that remains. So again, that is life-threatening. So with cirrhosis, there's a decreased removal of and conjugation of bilirubin. There's decreased production of bile, impaired digestion and absorption of nutrients, decreased production of blood clotting factors, impaired glucose and glycogen metabolism, and impaired conversion of ammonia to urea. There's decreased activation of hormones and drugs, and so we can lead to drug toxicity here. There's decreased removal of toxic substances of all kinds in the body, reduction of bile entering the intestine, so it impairs digestion and absorption of nutrients. backup of bile in the liver that leads to obstructive jaundice, blockage of blood flow through the liver, which leads to portal hypertension, and congestion in the spleen, which increases hemolysis. Inadequate storage of iron and vitamin B12 is present. There's congestion in intestinal walls and stomach that leads to impairment of digestion and absorption again, development of esophageal varices, which can lead to hemorrhage, development of ascites, which is an accumulation of fluid in the peritoneal cavity, can cause abdominal distension and pressure. The initial signs and symptoms are often pretty mild and vague, like fatigue, anorexia, weight loss, anemia, and diarrhea. There's a dull aching pain that could be present in the upper right abdominal quadrant. In advanced cirrhosis, ascites with peripheral edema will be present. The person will have increased bleeding. They might even have esophageal varices that could rupture, leading to hemorrhage and circulatory shock. And then they'll probably also be jaundiced and have encephalopathy. So this kind of shows the different effects of advanced cirrhosis on the body. You can read more about that on page 470. So to treat cirrhosis, first we want to recommend avoiding alcohol or whatever the specific cause was. Most often it's going to be alcohol, but not always. Supportive or symptomatic treatment, so whatever the symptoms are, we treat those. Dietary restrictions, balancing serum electrolytes, paracentesis to remove the fluid from the peritoneal cavity, antibiotics to reduce the intestinal flora, and emergency treatment, especially if there's esophageal varices that rupture. We want to, because a rupture of an esophageal varice can be life-threatening, and then potentially a liver transplant if it is caught early enough and the person qualifies. This is on page 467. I just put 467 and I feel like it's not that far back, but maybe it is. Yep, 467, it goes over the common signs and symptoms of liver disease. So then we have pancreatitis. So acute pancreatitis is an inflammation of the pancreas, which results in autodigestion of the tissue. It can be acute or chronic. Acute is a form that's considered a medical emergency. The pancreas lacks a fibrous capsule, and destruction can progress into the tissue that surrounds the pancreas along with the pancreas itself. There's a picture on page 471 of acute pancreatitis. There's dark areas of hemorrhage that you can see there. Substances released by necrotic tissue can lead to widespread inflammation. Chemical peritonitis results in bacterial peritonitis, and septicemia can happen. Adult respiratory distress syndrome and acute renal failure are possible complications as well. So some causes of acute pancreatitis are gallstones, alcohol abuse, and that sudden onset can follow an intake of a large meal or a large amount of alcohol. So we see this in the hospital a lot with people that are chronic drinkers. If they have a large amount of alcohol, they can come in with this acute pancreatitis. Signs and symptoms, so severe epigastric or abdominal pain that radiates to the back are the primary symptoms. They might also have signs of shock caused by hypovolemia, a low-grade fever until the infection develops, and then it can rise significantly, an abdominal distension and decreased bowel sounds because of decreased peristalsis and a paralytic ileus. So to diagnose, we do serum amylase levels. They're going to rise and then fall after 48 hours. We can do serum lipid levels. They'll be elevated. Hypocalcemia and leukocytosis will be present. And to treat, we're going to stop all oral intake. The person will be NPO. We're going to treat shock and electrolyte imbalances and any other symptoms they might have. But really, we just have to let the body rest with no food intake. This is on page 472, and it shows the pathophysiology of the acute pancreatitis. And then we'll move on to lower gastrointestinal disorders. So first we have celiac disease. It's a malabsorption syndrome. It's primarily a childhood disorder, but it can happen in adults in middle age. When I say primarily a childhood disorder, I mean it's primarily diagnosed in childhood, and then it sticks with them forever. There appears to be some sort of genetic link, but not always. There's a defect in intestinal enzymes that prevents further digestion of gliadin, which is a breakdown product of gluten. The toxic effect is on the intestinal villi, causes atrophy of the villi, and malabsorption and malnutrition are the result. The first signs will appear when cereals are added at about like 4 to 6 months of age. Signs and symptoms are steatorrhea, again, that fatty stool, muscle wasting, failure to gain weight, and the irritability and malaise. It's diagnosed by a series of blood tests, and a gluten-free diet is necessary for treatment. Um, Actually, not all people diagnose it when the child is that young. Sometimes it takes longer to realize what's going on because different kids are resistant to, or don't like, or don't deal well with certain foods to begin with. I know people that have had it diagnosed in early childhood when they kind of start to realize that they're not gaining weight and things like that. But I also have had friends that have had it diagnosed in like late childhood, early adulthood too. So it just depends on the person and how sensitive they are. Um, so again, that gluten-free diet is the treatment. If you can stick to the gluten-free diet, then you won't have the interaction that causes the issue. The intestinal mucosa can return to normal after a few weeks without gluten intake, and then it'll be as if there was no issue to begin with if you maintain that celiac or that gluten-free diet. Then we have chronic inflammatory bowel disease. We have Crohn's and ulcerative colitis. The causes are unknown. There's thought to be a genetic factor involved. Crohn's disease is often diagnosed during adolescence, and ulcerative colitis is usually diagnosed later in life, like in someone's 20s or 30s. There's lots of similarities between the two, so that's why they're kind of grouped together. So this is on page 474, and it compares Crohn's and ulcerative colitis. In Crohn's, it can affect any area of the digestive tract, but it's usually the small intestine. Inflammation happens, and there are like skip lesions where there are affected areas separated by areas of normal tissue. There's progressive inflammation and fibrosis that can cause obstructed areas, and damaged walls impair processing and absorption of food and nutrients. Inflammation is going to stimulate the intestinal motility, so you're going to see lots of diarrhea here. Interference with digestion and absorption happens. So you're going to see like issues with protein, vitamins, minerals. You might even see other malnutrition issues and steatorrhea. Some other complications are adhesions that develop between the loops. They can form fistulas, and in kids, they might even have delayed growth and sexual maturation because of all of these issues. So this is on page 475, and you can see, the affected parts. Then we have ulcerative colitis, where the inflammation starts in the rectum and progresses through the colon. The mucosa and submucosa are inflamed. Tissue destruction interferes with the absorption of fluid and electrolytes in the colon. If there's a severe acute episode, a toxic megacolon can develop, which is just a severe, inflammation of the colon. There's going to be diarrhea with up to 12 or maybe even more stools per day that contain blood and mucus accompanied by lots of cramping and pain. So this shows the normal colon and then the colon that has ulcerative colitis. And then we have irritable bowel syndrome. There's different types based on the primary symptoms of diarrhea or constipation or pain. There's abnormal gastrointestinal motility and secretion of some sort, a visceral hypersensitivity, post-infectious IBS, overgrowth of flora, food allergy or intolerance, or psychosocial factors. So signs and symptoms are lower abdominal pain and diarrhea, or constipation that alternates with diarrhea, or bloating or nausea. So to diagnose, we just use the signs and symptoms. We can test for food allergies, we can test for bacterial or parasitic infections, but there's no definitive thing that says that this has to be IBS. There's no cure for IBS as well, especially because, like I said, some of these are psychosocial issues. I always joke that there's nervous poopers and stuff like that out there, but that's very true. Some people get very, very nervous and they get either constipated or they get diarrhea from it. So some people just fluctuate or have this issue. And again, it's a psychosocial thing, so there's not a cure for it, so we just treat the signs and symptoms. So anti-inflammatory medications, anti-motility agents to slow the GI motility if it's a diarrhea issue, nutritional supplements, plenty of fiber and things like that, antimicrobials if we think that there's an infection involved, surgical resection if it is severe. Then we have appendicitis. This is an obstruction of the appendiceal lumen by a fecalith, a gallstone, or some other foreign material. The fluid builds up inside the appendix and microorganisms proliferate. The appendiceal wall becomes inflamed and purulent exudate forms, and the appendix becomes swollen. Ischemia and necrosis of the wall happens, resulting in increased permeability. So bacteria and toxins can escape into the surrounding areas and lead to abscess formation or localized bacterial peritonitis. The abscess can develop when inflamed areas are walled off. The inflammation and pain could temporarily subside, and localized infection or peritonitis can develop around the appendix and can spread along the peritoneal membranes. Increased necrosis and gangrene in the wall can be caused by increasing pressure to the appendix, and the appendix can rupture or perforate and release its contents into the peritoneal cavity, and this can actually be life-threatening. So anytime that we even suspect that there's an appendix issue, we'll get imaging or whatever, but if the appendix is acting up, we're just going to remove it, and we're going to have antimicrobial drugs. This is another one of those organs that we are not going to sit around and wait for it to rupture. If it ruptures, again, that could be life-threatening. It can, lead to infectious peritonitis that, like I said a million times, it's life-threatening, right? So we don't wait for that to happen. This is another one of those ones where there will be pretty intense pain, and then once it ruptures, the pain will be relieved. So we typically take these people back into surgery right away just to get rid of it before we have those complications like a rupture. And this shows you the typical progression of appendicitis. You can see this on page 478. So usually they're going to have this pain around the umbilicus that's related to the inflammation. They might even be nauseous and vomiting. The pain becomes severe and localized in the lower right quadrant, and we have what we call rebound tenderness. So if we push down, the pain is temporarily relieved, and then we release, and they're in pain again. After the rupture, again, that pain subsides temporarily, but that's a problem. The pain will reoccur. It's usually going to reoccur very severely. They'll have a low-grade fever and leukocytosis while it's inflamed, and then their fever will spike if there's a rupture. They'll have like a very rigid abdomen, tachycardia, hypotension, and as that peritonitis develops, the abdominal wall muscles might start to spasm, and those toxins can actually lead to that hypotension. And then we have diverticular disease. So we have a development of diverticula, which is like an outpouching or herniation of the mucosa through the muscular layer of the colon. Diverticulosis is asymptomatic diverticular disease, and diverticulitis is when those outpouchings or those diverticula are inflamed. So if someone has diverticulosis, and then when it's in a flare-up, it's diverticulitis. So these diverticula or these outpouchings form at gaps between muscle layers. If there's a congenital weakness of the wall, that might be a factor. Weaker areas are going to bulge when the pressure increases, and there's lots of cases where this is completely asymptomatic. Diverticulitis, stasis of material in the diverticula, leads to inflammation and infection. So when these outpouchings are inflamed or swollen, they're going to like kind of catch different food and materials, and those can lead to infection there. This can cause cramping, tenderness, nausea, vomiting, a fever, elevated white blood cell counts. So to treat diverticulitis, we use different antimicrobial drugs, but really to prevent diverticulitis, if someone has diverticulosis, we want them on a low residue diet. We don't want any tiny little particles that can get stuck in those diverticular outpouchings. So we don't want them to have anything that has seeds, or any like little particles like that. So this is on page 479. It shows you the diverticulosis. And then we have peritonitis. So this is inflammation of the peritoneal membranes. We talked about peritonitis being a symptom or a sign of a couple different things that we talked about in this chapter. Chemical peritonitis can be because of enzymes released with pancreatitis, urine that leaks from a ruptured bladder, chyme that spills from an ulcer, bile that escapes from a ruptured gallbladder, blood, any other foreign material in the cavity. We talked about an appendix that ruptured as well can cause a chemical peritonitis. So this is on page 486, and it talks about the development of peritonitis. So bacterial peritonitis is caused by direct trauma that affects the intestines. A ruptured appendix, I guess ruptured appendix could be under either chemical or bacterial, especially if it is a bacterial issue that is inflaming the appendix. Intestinal obstruction and gangrene, any abdominal surgery if foreign material is left or there is an infection that develops, and pelvic inflammatory disease in women can cause peritonitis as well when the infection reaches the cavity through the fallopian tubes. Signs and symptoms are sudden, severe, generalized abdominal pain, localized tenderness at the site of the underlying problem. Vomiting is common with abdominal distension, dehydration, hypovolemia, low blood pressure, and tachycardia, fever, and leukocytosis. So to treat, it depends on the primary cause. Surgery might be required to kind of clean out the peritoneal cavity from whatever's, causing the inflammation or infection or whatever, but they're definitely going to get a massive amount of antimicrobial drugs that are going to be specific to that causative organism. And that is it for Chapter 17 over GI.